If you're in the same world that I am in, then you're familiar with some happenings in the recent past that has left people shocked. I'm talking about suicide. We've had some big names being mentioned that have taken their lives. If not that, then you are familiar with suicide around you, in your neighborhood, in the society that you're in. Now, this is a serious thing. And that's why we have an expert today who is known as Dave Jobs to come and speak to us about it. Now, this is Book Talk. At Book Talk, we have authors come and tell us about their books, their wonderful books. And so, Dave is an author and he's going to be here and tell us more about that and even much more than I have introduced him. So, let's go and meet Dave. And let me remind you, please share this episode with all your friends, whatever it is that you are watching us or listening to us. Even if you get to listen to us or watch us after we are through with this, remember to share it with everybody around you. And now let's go and meet Dave and hear about his book. Here we go. Hi, Dave.
Hey, Anthony. Good to see you. Thank you so much for having me.
Good to see you too. And thank you for coming to Book Talk.
Of course.
It's such an honor to have you here. Where where are you right now? Why are we
I'm in
here?
my home in Bethesda, but I'm just outside of Washington D.C.
Mm-hmm.
And I work at Catholic University in the northeast corner of Washington D.C.
That's wonderful. And what is it that you do? Tell us about your occupation and let's get to know you a bit before we dive into your book.
Sure. I'm a clinical psychologist by training, so I'm a PhD in clinic. I have a PhD in clinical psychology, and I'm a university professor. And I direct a lab called the Suicide Prevention Lab at Catholic U. So that I'm a full time academic. And a lot of what I spend my time, Anthony, doing is clinical trials. So we have funding from the National Institutes of Mental Health and from the National Institutes of Alcohol and Alcoholism, and from the VA, from different organizations to conduct clinical trials with patients and clients who are struggling with suicidal risk. That's a big focus of my professional life.
Okay. And if I may ask, how far back did you start writing? Now you've been in practice, but then how far back did you start putting your work into books?
So I've been in the field for about 40 years since graduate school.
Wow.
So I'm an old timer and have lots of experience. And this particular intervention about which this book is written has been in development since well, about 35 years. So it's a long term investment of time and love and energy.
Mm-hmm.
And so I'm a clinical suicidologist, which means that I'm focused on training and assessment and treatment, systems of care, and how we work with people that are struggling in this way. And this is the third edition of a series of books that I've done with Guilford Press, and it's the crowning glory. It's the capstone to the series about this intervention.
Hmm. That's cool. Now, for those of you who may have jumped in right now, we have not introduced the book. Here's the book that we are talking about: Managing Suicidal Risk, a Collaborative Approach by David A. Jobs. It's just about to be released, if I'm clear.
I think it's out. I mean, the ebook has been out for a little while, and
Mm-hmm.
it officially gets in print August 18th. But they're selling it, so I count it as being out.
Okay. So there was the first edition, second edition. This is the third edition. So it means that there are improvements to it. This is what I believe. It's a work in progress.
Absolutely. So the
Mhm.
first edition was very much focused on assessment, and it
Okay.
was trying to convince people about this intervention that we'll be talking about, and to kind of make the case for it. So there are things about this intervention that are really different. Like we try to keep, for example, people out of the hospital because we think that's in their best interest oftentimes. We don't focus on mental disorders. We focused on ideation and behavior. And so we don't treat depression per se. We treat what makes somebody suicidal.
Mm-hmm.
And so that first book was very much about how you do this assessment. This is patient centered. It's very collaborative. It's empathic, obviously. And then the second book was about treatment and intervention.
Mm-hmm.
That was pretty much a big pivot point in terms of thinking this as a treatment. Now the third book is thicker and fuller with all the clinical trials that we've done and the pearls of wisdom that we've garnered over these 35 years. And it really is meant to be the sort of the bookend to the series of these books on this topic.
Maybe, and I believe there is someone out there who's listening to this or
Mhm.
watching, and he doesn't have a clue of how to go about these things. I mean, you with someone or you meet with someone who's
Yeah,
suicidal, and
yeah.
I believe this is the reason that you've written this book. Or who is the book aimed at exactly?
The book is aimed at clinicians, but
Mm-hmm.
that includes psychiatrists and social workers and psychologists and counselors and other people that work in crisis intervention and in mental health more broadly, nurses, for example.
Mm-hmm.
So it's a manual for treatment, but it also proposes, Anthony, a philosophy of care and an approach to care. There
Mm.
are 15.6 million Americans who have serious thoughts of suicide.
Mm-hmm.
That's a huge public health crisis.
Yeah, it is.
And the ideation levels just keep going up, especially since COVID.
Mm-hmm.
And so this book is really targeting people like that who struggle, who can find a clinician that knows this intervention. And this book is then the source book for clinicians to use this intervention, which is called the Collaborative Assessment and Management of Suicidality, more easily understood as CAMS. So the CAMS intervention is what this book is about.
Oh, that's wonderful. But I've had people who here who come with such a complex idea, and
Yeah,
because to some of us who are not clinicians
yeah,
and have no experience with some of the terms that we could meet in the book,
yeah,
uh, I said I've come across some of such, but then they have ended up helping me even though I am not in that field, because I know you're going to share some things that are going to be helpful to someone who has
yeah,
no clue of being in the hospital as a doctor, as a clinician. Or
yeah.
hmm
Well, I've known people that just read the book because they find the philosophy valuable
hmm
and therapeutic in itself. That's not necessarily how the book is written, but the idea here is that the book is written in the first person.
mm,
So it's not this academic scholarly treatise. It's written as if I'm talking to you in the first person.
okay.
So there's lots of anecdotes, a lot of case examples of things that I've been through in my career that makes it accessible and readable. I think in that regard, and the critical feedback has been that it's a really understandable, readable book. And then the thing, Anthony, is that CAMS is really focused on the patient and what they're going through.
hmm
And a big part of the treatment is to ask this person who's struggling, what makes you think about suicide?
hmm
And we call those drivers, and that's what we target and treat in the intervention. And believe it or not, that's a really novel way of thinking about this because most people think, oh, it's depression or it's psychosis or bipolar, major depressive or manic depressive disorder.
mm,
And people assume that, going to the hospital for 4 or 5 days or taking medication is necessarily going to help with the suicide risk. And actually, medications don't have that much impact on suicidal ideation and behavior.
hmm
Hospitalizations oftentimes are associated with increased risk following discharge from the inpatient setting. So CAMS is meant to be a remedy for what's commonly assumed to be effective and is not. And CAMS is quite effective because we do randomized controlled trials and clinical trials to prove its efficacy in different populations around the world.
Wow. So comes the collaborative assessment and management of suicidality.
Yep.
And you tell us that you have some case studies because we are listening could be interested in knowing. I'm not a doctor, but then I could see some signs, I could hear some stories, I could see some reactions from a person and know that this person is thinking of suicide. How to give us a few tips here and there.
I think the biggest thing in terms of just layperson tips would be, just noticing that someone's not themselves
Mm,
and that they're dropping hints that they don't know if it's worth it anymore, or sometimes they just wish you could take a long vacation. And a lot of people who struggle in this way actually do give voice, to thoughts of suicide.
mm-hmm,
And the biggest thing that we say to parents or to friends or spouses or partners is that if you have concerns about people, you should, really ask them forthrightly. It sounds like you're very distraught. Have you had thoughts of ending your life? And to be direct and matter of fact about it, but then be prepared for the response. There's a really excellent book, which you'll appreciate being a book person, by Stacy Friedenthal, that's published by New Harbinger. It's a book about loving people who are suicidal.
mm-hmm,
I wrote the foreword to the book, so I'm a very, very big fan of it. But the idea is that there are sensible things that you can do. The author Stacy Friedenthal, and you should have her on your podcast because there's just so little information out there about what people who are concerned about someone should do.
mm,
And so they assume that, calling the emergency department or taking their loved one to an inpatient setting or the emergency department especially is going to be a therapeutic experience, when I'm sorry to say oftentimes it's not.
mm,
It can be very upsetting, and people might wait 10, 12, 18 hours to see the doctor.
mm-hmm,
And then if they are admitted to the inpatient unit, they might only be there for 2 or 3 days.
mm-hmm,
And the only treatment they really get is medication. And as I noted, medication isn't necessarily helpful with suicidal risk.
mm-hmm,
So we're trying to change the paradigm here and get people aware that there are effective outpatient treatments like CAMS and others that are in the field that are not widely used by clinicians, but we're trying to change that. We're trying to get clinicians to use things that are more effective, proven by clinical trials, than just the way we've always done it for decades, since medieval times, which is that a person who's suicidal is by definition crazy. So we need to control them until they are no longer crazy, which means they'll no longer be suicidal.
mm-hmm,
And that's not how it works, Anthony. It really doesn't work that way. People are suicidal for very legitimate reasons.
mm,
And if we treat those reasons, invariably we can help the patient or the client come to see that they can manage these thoughts and feelings. And a big part of CAMS is trying to shift their focus to reasons for living and what would make life worth living. And
mm.
that's really the sort of the back end of the intervention, is to really focus on plans and goals, hopes for the future, and purpose and meaning.
So how do we go about that?
Yeah. So mostly in an outpatient setting. And the first session involves a lot of assessments. So there's something called the Suicide Status Form, or
Mm-hmm.
the SSF. Acronyms make things easier.
Yeah.
And this SSF is a administered side by side. So I'll ask permission to take a seat next to the patient to go through the SSF with them, and they actually fill out the first page. And so I'll help them with that. It's collaborative, and it will be different ratings and different responses that describe for them what they're going through with regard to suicidal risk.
Mm-hmm.
Reasons for living, their reasons for dying, the nature of their psychological pain, their hopelessness, different kinds of constructs. And I'm following them all along the way.
Mm,
And what the patient experiences is validation that we get it, that we're not judging them. We're never finger wagging. We're just, we understand what their suffering and struggling is like.
mm-hmm.
And that in itself is therapeutic, Anthony? Is just being understood and not judged is therapeutic?
Mm.
Then I take the SSF back as the clinician, and we go through different kinds of what we call risk factors and warning signs.
Mm.
Like, have you thought about a plan? Is there access to lethal means? Do you have a firearm that's available? To then ultimately get to a point where we say, we need to develop a treatment plan to keep you out of the hospital.
Mm.
But to keep you out of the hospital, we have to have a stabilization plan. So if things get tough, you know what to do. And so we work through the stabilization plan. And at the end of that first session, I'll say to the patient, okay, I got a sense of what we can do, to get you through your dark moments. What are the two things that we've discovered that compel you to think about suicide? And overwhelmingly, Anthony, people will say, well, my girlfriend is leaving me, or my kids don't talk to me.
Mm.
The vast majority of drivers are relational issues.
Mm.
Being alone, being divorced, whatever that might be. My loved one just of 40 years just passed away.
Mm.
And then people wrestle with things like vocation, what they're doing, the job that they have but they hate, uh,
Mm.
and also issues of the self. Their self-esteem or how they feel about themselves. And a small percentage are focused on their symptoms of like depression or anxiety. It's really kind of work and love and how people feel about themselves that people say are at the heart of why they're suicidal.
Mm.
So that first session is pretty labor intensive, but now we've got our marching orders so that when we go into interim sessions, the sessions between beginning and end, we're just going to focus on your drivers.
Mm.
That might be a case of a soldier who has post-traumatic stress disorder from combat in Iraq,
Mm.
where his wife and he are estranged and their marriage is sort of on the cusp of breaking up, and he's drinking too much. So interventions with him would focus on treating his PTSD, also maybe some couples therapy for he and his wife. And as we intervene with these drivers, we don't necessarily fix them altogether, Anthony, but we change them enough so that the patient feels like they can manage the suicidal thoughts and feelings and they're behaviorally stable.
Mm.
And the case I'm referring to, it's an actual case that was in a VA in South Carolina. This veteran was effectively treated with prolonged exposure for PTSD, which is a very effective evidence-based intervention, but then developed moral injury
Mm.
because some children had been killed in a firefight. So we brought in a priest to actually do spiritual guidance with him as part of CAMS.
Okay.
And he resolved in 8 sessions. And that is the modal response to the intervention. 6 to 8 sessions, most people respond to CAMS.
Mm.
So it's kind of having the patient come in and look at suicide this way, and then over the course of care, they look at it this way. And then at the back end, we're talking about, so let's look at your reasons for living. What would give you a sense of purpose and meaning? What would make your life worthwhile?
Mm.
And a lot of times we can kind of create a trajectory or sort of send this person out the door with a sense of, of a different direction or adjustments they need to make in their relationships. But that's what we do. And it's 6 to 8 sessions and it's saving lives.
That's wonderful. Are you saying 6 to 8 or 68?
Six to
To
eight.
8, 6 to 8, because yeah, 6 to 8
I mean,
sessions.
it's a very brief. It's a very very brief intervention.
Yeah,
And
that's
and
quite
the
a.
and the thing that we like about it, so there are things called meta analyses, which are big studies of lots of studies. And so there've been 2 meta-analyses of CAMS, and the single biggest finding from the most recent meta-analysis of 9 different trials is that CAMS increases hope and decreases hopelessness,
Mm.
while it reduces suicidal ideation and overall stress and suffering. And so these are really important to saving lives because these are the things that people suffer and struggle with. And if we can give them a sense of hope and what we call post-suicidal life, then we've achieved our mission.
That's good. And we thank you for taking this. It's your career, yes, but then they are not. I mean, some of us have never heard that there is such an area of
Yeah.
that you are a suicidal preventer. and
Yeah.
that's your career, that's your profession. So
It's a fairly young field, mind you, it's about 50 years old. So
okay.
in science and in clinical science, that's a pretty young field, and we've
Mm,
seen maybe only the last 5 to 10 years there being a broader recognition and a body of literature that really supports the kind of stuff that I'm talking about.
yeah, and is important, and especially because of the challenges that you mentioned, they are in the increase. We have relationship issues every single day. Then the world is experiencing some unexpected turns, like
Yeah.
recent COVID-19, and there are always cases of things happening every single day. I mean,
We have 2 clinical trials right now, Anthony, with, college students. So
okay.
this is called a multi-site study
Mm-hmm.
all across the nation, 4 different counseling centers. And then we have 2 clinical trials with teenagers. And one of the things that we're seeing since the pandemic, which I've never seen before, are what are called social determinants. So we've had patients. We had a patient from an African country actually who was a nursing student who talked about racial and gender oppression
Mm-hmm.
as one of the reasons that she was thinking about killing herself,
Mm-hmm.
which I didn't used to see. We have college students saying, "The Earth is dying. I'll be forever in debt.
Mm-hmm.
I'll never own a house." And this is new, and we're actually studying this. But these are, as you're saying, sort of what we call social determinants that are now weighing on young people in particular, especially young people of color,
Mm-hmm.
where levels of ideation and attempt behaviors have actually increased significantly, much more than the white males, which dominate the completed suicides in our population.
Mm. And then there is that social status that I am, and with the social media that we have here, I'm comparing myself to
Of course,
my former mates, and that icon that I am always following. And I'm
of
saying
course.
that's a far distant land to reach. I may never get there, so I better give up.
Social media is interesting because everybody wants to just sort of say it's the cause of the problem, especially with young people.
Mm-hmm.
And for some subset, that's certainly probably true, but it also represents some of the remedy. We have, for example, an intervention called Jasper Health, which is if you go to the emergency department after you do your initial interview, they'll hand you a tablet, and then you can engage with this app that's on a tablet
Mm-hmm.
to learn about different problem solving skills. You can learn about breathing exercises. You can learn about, and along the way, we're asking you questions so that when your doctor shows up 8 or 10 or 12 hours later, he or she has a much more detailed level of understanding about who you are because
Mm-hmm.
we've been asking you questions along the way. And a lot of it's informed by CAMs. And then what we do is offer you can watch videos of puppies, or you can dial into people who have lived experience, which are people who've been through what you've been through, and they're describing their stories of hope and recovery.
Mm-hmm.
And we see in the clinical trials, we see patients, very engaged, up to 4 to 5 hours just with the app alone on the platform.
Mm-hmm.
And then they can download what they like to their smartphone.
Mm-hmm.
And then by the time the doctor does show up, they're much calmer. They're much more centered. Lethal
Mm-hmm.
means at home have been made secure. We've made arrangements for their disposition, which means when they leave the hospital,
Mm-hmm.
and they're in a much better place than when they came in. And this is just technology, at its best, helping assist the doctor who maybe has 15 to 20 minutes to talk to you.
Mm-hmm.
So I'm sort of like straddling, yes, there's absolutely bullying and peer pressure and competition and fear of missing out that we see in social media for sure.
Mm-hmm.
And that contributes to a lot of the distress of young people, for example. But there's also technological solutions, I think, to the problem as well.
Mm-hmm. Wow, that's proper use of technology because
Hopefully.
yeah, it's proper use of technology. Now, we you talk about uh, comes as a mean of decreasing malpractice liability. Tell us
Yeah.
about this.
Yeah, this is a big one for the United States because a lot of clinicians who you think know what they're doing don't know what they're doing when it comes
Mm-hmm.
to suicide risk.
Mm-hmm.
Less than a third receive even an hour on the assessment of treatment in either medical school or their graduate training.
Mm-hmm.
So the public and the media thinks that mental health professionals who are licensed know what they're doing, and the vast majority of them don't,
Mm.
which is maybe shocking to hear.
Mm-hmm.
And on top of that, then many mental health professionals will try to get rid of people who are suicidal because they're afraid if someone dies while they're working with them, they're going to be sued for malpractice.
Mm-hmm.
So that's a real threat, and it ends up causing clinicians to practice defensively, which means they're hospitalizing people that don't need to be hospitalized. They're getting rid of people that they could actually work with quite effectively.
Mm-hmm.
And they're sending the message to the person who struggles, you're a problem. You're too much for me. I can't deal with you.
Mm-hmm.
I need to hand you off to a psychiatrist and you need to take medication.
Mm-hmm.
What what that means then is that people aren't getting the help that they need. So the biggest way to reduce malpractice liability across medicine and then specific to this topic is to document well what you do.
Mm-hmm.
And the SSF that I described before is used in every session. That is done with the patient as we're meeting, and that it becomes the medical record.
Mm-hmm.
So documentation piece is built in. Now, if
Mm-hmm.
I'm seeing you on telehealth, we can do this online, and I can pull up and share my screen and share my SSF and fill it in for you. But the medical record is being completed all the while we're doing CAMs.
Mm-hmm.
So the single biggest protection for mental health practitioners who are afraid of being sued is to document well what they do, to have treatment that is suicide focused, and to do something that's effective, which this is. So we can't guarantee that there isn't some crazy plaintiff's attorney that's not going to go after somebody, but they're only going to go after a mental health professional if a tragedy should occur, if the documentation is terrible.
Mm-hmm.
And by using CAMS in the suicide status form, the documentation is actually quite excellent.
That's good. I'm curious, as maybe other people are. How is the flow of the book? Can we hear some text from it? Maybe read as a one case study because you say that you have some case studies there, or anything that you
I
maybe.
just happen to have the book right here next to me.
Okay.
So
And
this is chapter.
those
This is
who are
chapter.
watching, those who are watching are saying it's a very insightful engagement. It's a
All right.
good book. Yeah.
So this is from chapter 1.
Mm-hmm.
Carmen, a 16-year-old second-year public high school student, has been distraught by her parents' bitter divorce. Carmen's mother is from Puerto Rico, and her father's an Asian American of Chinese descent. As a mixed race only child, Carmen struggles with loneliness and her cultural identity. Like many high school teens, Carmen has also struggled to find a close group of friends. To this end, Carmen is extremely active on social media and is determined in a determined effort to connect with peers and make friends. Following a difficult first year in high school, Carmen began to develop friends in the drama club. She fell in love with Eric, a popular boy in last year of high school, his senior year, who's often the lead in school plays and in musicals. Her interest in Eric was unrequited. At a party with her friends, she was drinking. Carmen got drunk and had sex with Eric. Carmen subsequently announced through social media that she and Eric were a couple. Eric, in turn, denied this notion on social media and noted that Carmen was a pathetic loser and crappy in bed. A series of Instagram and Snapchat messages ensued, and the Carmen's Drama Club peers began taunting her about Eric's characterizations of her. After a few days of online bullying, Carmen posted a Snapchat message about quote unquote ending it all. And she promptly overdosed on all the medications in her mother's medicine cabinet. One member of the drama club, who was alarmed by the post on social media, told her mother, who called Carmen's mom. Carmen's distressed mother raced to Carmen's bedroom and found her seizing on the floor of her room in a pool of vomit.
Mm-hmm.
So this is based on a case that I saw a number of years ago
Mm-hmm.
of a young teenager who, just like Carmen, and how I characterize her, who was brought in after being hospitalized for a few days by her parents, and very reluctantly, was willing to try to do CAMs with me.
Mm-hmm.
And I saw her for 12 sessions. And this case study goes through the course of the book. So the book opens with this.
Mm-hmm.
And then as I'm describing the intervention and for clinicians how to do the intervention, they're getting sort of snippets of Carmen's story. And it's not all roses. I mean, she does okay, and then she has a crisis with a couple of her friends, has a major setback, almost takes another overdose,
Mm-hmm.
but then regroups, and her friends rally around her, and then she does better, and then she resolves. And I continue to see her for several months, but we ended after about 8 months together. And the
Mm-hmm.
book ends with the outcome of her several years later, when she's in college. So that's just an example of kind of the flavor of the tone. It's meant to really be relatable, and for clinicians to recognize people like Carmen, because clinicians see kids just like her.
Mm. Wow, that's wonderful. And we know that the book continues to be better and better as you go deeper and deeper.
Well, the book has sold 55,000 copies, which for a trade book is actually pretty good.
Wow. Wow.
And that's because I think there's very little competition,
Mm-hmm.
because it's relatively affordable. And the other thing that's sort of unique about this, Anthony, is that there are a number of tools that are in the back of the book that can be downloaded.
Okay.
And then through an arrangement at Guilford Press, you can also get online versions of these to use within electronic medical records.
Mm-hmm.
So it really provides a lot of tools and resources for clinicians as well. And that's a kind of a unique thing about the book, is that by virtue of owning the book, people can use the intervention. If they want to learn more about the intervention, they can go to the CAMS Care website, and we have a sort of integrated training model that has been evidence-based and proven to be effective. But this is how we're trying to change the world. We're trying to change, the way clinicians approach the topic of suicide. We're trying to create resources for families and friends who are concerned about their loved ones, that there is an intervention and other interventions like CAMS, not a lot, but several of them, that have a robust evidence base and have been shown to make a difference in people's lives.
Hmm. Wow, thank you for that. So, for anybody who may have found us going on, we are talking about the book Managing Suicidal Risk, a Collaborative Approach by David A. Jobs. And to get the book, you can go over to CAM's website, which is www.cams-care.com. That's
Yep.
cams-care.com. Thank you very much, Dave. We really appreciate you coming to this episode of Book Talk today and for sharing with us this wonderful news about this great book.
Well, thank you, Anthony. I so appreciate your time, and good luck to you. And thanks so much for having me on.
Yeah, thank you. We are almost coming to the end of the show, but before you go, we'd like you to leave us with a few words that we should always remember. What are they coming from you?
Life gets hard, and certainly these days we know we're a divided country, and there's a lot of issues in play. Social determinants are making our lives very difficult, but there's always hope. There's always hope, and there's effective care that's out there. CAMS is one version of that. But before doing something as dire as ending your life and your biological existence forever, it's worth your while to find out about what's effective care look and what it looks like, and to seek that care to maybe hold the day and have a life that you could find someday that's worth living with purpose and meaning.
Wow, thank you for such wonderful words. Once again, we thank you for coming to Book Talk and for sharing with us such an interesting and wonderful topic.
Great. Thank you, Anthony.
Yes, this has been Book Talk. I have been your host, Anthony Moirore, and together with our guest today, Dave Jobs, we say keep reading and keep impacting the world positively. Thank you for now, and until next time, it's bye
So
from
long.
us. Yeah, shalom.